welcome you all. My name is Dr. PG Madam Rafi. Today we are going to discuss about congestive heart failure. So first of all, we will see what is heart failure. Heart failure means here heart is not able to pump proper blood supply to the body demands. Okay. So heart is not able to pump proper blood supply. So what are the types we'll have? We'll have two types. Low output failure means where heart is not able to pump proper blood supply. High output where heart is pumping proper blood supply but is not meeting the body demands. Okay. What are those types in high output failure? We have severe anemia, thyrotoxicosis, thiamine deficiency. Okay, when patient is having heart failure at acute condition, body will have compensatory mechanism. Okay, body will develop compensatory mechanism. How that compensatory mechanism will form? Okay, we will see how that compensatory response will happen in during heart failure. Okay, so it is an acute condition. Normally, heart failure is started. So that means force of contraction and pressure will decrease. Okay, therefore what will happen? There will decrease blood supply to the kidneys. When decrease blood supply to the kidneys, what will happen? That this glomerular filtration also decrease. When glomerular filtration will decrease, obviously there will be more chance of sodium and water retention. Okay, that is one way. Second is when kidney is getting less blood supply, kidney will activate a RAS system. RAS means renin, angiotensin, aldosterone system. One this RAS system is get activated, there will be increased renin release. Okay, this increased renin release will cause increase of 81 this one aldosterone. So when finally increase aldosterone will form sodium and water retention, it will lead to cause cardiac remodeling and ventricular dilation. There further will cause failure. Okay, next this is one by kidneys. There will be another way also there, that is by increasing sympathetic discharge. This sympathetic discharge will be increased by activation of carotid receptors in the carotids. Okay, when these carotid receptors will get activated, there will be increased sympathetic activity. It will lead to cause vasoconstriction, that means increased blood pressure. Beta 1 increased heart rate. When pressure is increased, heart rate is increased, obviously preload and afterload both will get increased. So this regulatory mechanism will increase initially cardiac output. Okay, so if this mechanism will be sustain the cardiac output for some time. If that there will be some pathology will be there hidden there, so obviously this compensatory response will not be prolonged such a time. So first it will be increased cardiac output. So if it will be maintained for 1 week or 2 weeks. If it is further more, obviously there will be drop in cardiac output. Okay, so this how there will be two compensatory response. One is by kidneys, second is by sympathetic activity. Okay, so this by two mechanism body will develop compensatory responses during heart failure. Here the main pathology will be whether by kidneys or by sympathetic, they both will cause cardiac remodeling. This cardiac remodeling by kidney will due to aldosterone. Okay, this aldosterone will causes cardiac remodeling. If cardiac remodeling will happen, obviously ventricular dilation, so there will be more fluid will get accumulated. It further leads to cause heart failure. Okay, thereby this is the compensated response. Okay, so what are the drugs we will use in this heart failure? We'll see in following slides. Okay, next we'll discuss treatment of heart failure. Okay, so normally in heart failure we'll use certain group of drugs. We'll discuss this one followed one by one. First we'll discuss diuretics. Diuretics is the main important drug. Okay, in heart failure what is the main pathology? First will be volume will be overloaded, heart is not able to pump. Okay, so for that one volume overload, what will you do? You have to flush out the extra volume by giving diuretics, that is loop diuretics. Thereby will reduce the preload. So cardiac burden will be decreased. In diuretic there will be one more drug that have additional beneficial, that is spironolactone. It is potassium sparing diuretic. Its beneficial is they reduce cardiac mortality. How means they reduce the remodeling of ventricles. Okay, by reducing ventricle remodeling, they reduce mortality rate in CHF patients. Okay, so first drug is diuretic. Why means they flush out the extra volume. Okay. Now we have to increase the contraction. How we will increase contraction? By using inotropic drugs. What are the inotropic drugs? We will have DOBU, DOPA, cardiac glycoside, that is digitalis drugs. Okay. So in inotropic, DOBU is beta 1 agonist. Obviously increase rate of contraction. its TF is 2 minutes. So we will use IV infusion. Then DOPA. DOPA will have different doses, and different doses of DOPA will have different effects on different receptors. So it will act on 3 receptors: DOPA, B, beta receptors and alpha receptors. So when you are giving in 1 to 2 microgram, that is low dose, it will act on only dopamine receptors of renals. So it will cause vasodilation. When you are giving 2 to 10 microgram, it will act on beta 1 receptors. Okay, thereby it will increase the contraction. When you are giving in high doses, that is greater than 10 microgram per kg body weight, so obviously it will act on alpha 1 receptors, thereby increasing vasoconstriction, thereby rising BP. Okay, so this how the DOPA will have different effect on different doses and different receptors. Next inotropic drug will be cardiac glycosides, also known as digitalis. It is main MCQ, obtained from Digitalis purpura. It is a plant. Examples of cardiac glycosides will be digoxin, digitoxin, stopanthin, ovapin. Okay, these actions will be different from other inotropic drugs. They decrease heart rate and oxygen consumption, thereby decrease burden on heart. Okay, so we will see the mechanism action of digoxin in next slide. So this is mechanism action of digoxin. Okay, digoxin is mainly acting on main one enzyme, that is sodium potassium ATPase enzyme. This is most commonly repeated MCQ. So it will act on sodium potassium ATP enzyme. It is present in cardiac cell membrane. When this digoxin is inhibiting this sodium potassium ATPase, what will happen? Obviously there will be no sodium and potassium exchange. So there will be sodium retention will be in cardiac. Okay, when sodium and potassium will not exchange, this sodium will get accumulated in the cell membrane. So obviously accumulation over a certain period, what will happen? Hypernatremia, increased sodium levels. When this increased sodium level, obviously this sodium will have another exchange, that with sodium calcium exchanger. When this sodium will not exchange with calcium, okay, so obviously what will happen? There will be rise of calcium inside the calcium membrane. This inside calcium, what will happen? There will be increasing calcium will go and bind on sarcoplasmic reticulum, that is this TNC, troponin C receptor by RYR receptor. Okay, that is cardiac receptor will be there. When this extra calcium will go bind on to the sarcoplasmic reticulum, it will be stored there. Okay, continuously. When this cardiac cell will get depolarized, it will have signal from L-type calcium channel. When this L-type normal depolarization, obviously it will causes more releasing of calcium into the cytosol. There will be more contraction, leads to inotropy. Inotropy means increased contraction. How this increased contraction will happen? By accumulation of more calcium in the cell membrane will lead to cause increased contraction. Okay, here the main MCQ will focus on what are the main enzyme inhibited by digitalis drugs is sodium potassium ATPase. By inhibiting this one, what will happen? Retention of sodium. By retention of sodium, obviously it will not exchange with calcium, so obviously there will be rise in calcium. This increase in calcium will go by stored in sarcoplasmic reticulum. When normal cardiac depolarization will happen, this calcium there will release more from the sarcoplasmic reticulum. When more it will release into circulation, obviously the more will contraction. Normally calcium will helpful for contraction. When more calcium will be released, more contraction will happen, thereby increase contractility activity, that is inotropic. Okay, here MCQs will be sodium potassium ATPase. Second one is this digoxin is contraindicated in right heart failure. Okay, main thing in right heart failure you will not use digoxin. Okay, or digitalis drugs. There will, what are the drugs in we will use in right heart failure? Diuretics, vasodilators, phosphodiesterase inhibitors like sildenafil, all those drugs we will use, but we can't use cardiac glycoside drugs. Okay, next one is, here one more thing is, when patient will have hypokalemia or hypercalcemia, will not use digoxin because they both aggravate digoxin toxicity. Okay, because when hypokalemia will be there, there will be chance of no exchange. Okay, when hypercalcemia is there, obviously it will lead to more further calcium retention, more arrhythmias will, more chance of arrhythmias will be there. Okay, that's why when patient is having hypokalemia, Hypercalcemia, will not use digoxin. When patient is in right heart failure, will not use digoxin. In case digoxin toxicity happen, what will we do? We'll use dizibind. It is an antidote for digoxin toxicity. This is also an MCQ. Okay. Next drugs will be inodilators. Previously, what we'll see? We'll see diuretics, inotropic drugs. Next, inodilators. Inodilators means in the name itself, it is an inotropic and vasodilatory. Inotropic means increased contraction. Vasodilatory means vessel dilation. Okay. So what are the drugs we'll have? Inamrinone, milrinone, anaximon, and vesnarinone. Okay. These drugs mechanism of action is, these drugs will inhibit phosphodiesterase enzyme, thereby raise calcium, okay, cyclic AMP. So when increasing cyclic AMP will cause more retention of calcium, thereby will cause vasodilatation. Okay. What is the major adverse effect of this inodilators is thrombocytopenia is main thing. Okay. In inodilators we'll have two, inotropic, vasodilatory. Adverse effect will be thrombocytopenia. What is the mechanism of action? They inhibit phosphodiesterase enzyme, thereby increase cyclic AMP, causes vasodilatation. In inodilators, this is a new developed drug, levosimendan. This mechanism of action is different from this inodilators. This mechanism of action is they sensitize the cardiac myocardium for calcium. So when the calcium sensitization will increase, obviously they will have chance of more calcium binding, increased contraction, are the first mechanism of action. Second is it will causes opens up potassium channels, thereby causing vasodilatation. One by obviously contraction, second is vasodilation. That way it is known as inodilator. Inodilator is main two mechanisms. One is contraction, next vasodilation. Okay. Next drug is natriuretic peptides. Natriuretic peptides will have two types: atrial natriuretic peptides, brain natriuretic peptides. When heart is unable to pump, there will be more overload. This ANP and BNP will produce by heart. Okay, ANP is produced in atrium, BNP is produced in ventricles. Okay, so when these drugs will do, their main action is natriuresis. Natriuresis means losing of salt and water. Next is vasodilation. Obviously, it will losing, one thing is losing volume, second thing is vasodilation. So obviously decrease burden on heart by pumping more blood out. Okay. So ANP analogs will be uralitide, urodilatin, and BNP analog is nesiritide. If they are asking exam MCQ means BNP is produced from ventricles, ANP is produced from atrium. These are the action is by they decrease in cardiac burden by causing natriuresis and vasodilatation. Okay. Next drug is vasodilators. Okay. Vasodilators means here obviously they will cause vasodilation by three drugs: venodilators, arteriodilators. Some drugs will have both venodilators and arteriodilators. Venodilators mainly nitrates, they decrease preload because of dilation of venules. The cardiac preload will be decreased. Obviously, when cardiac preload will be decreased, it followed by afterload also decrease. So they decrease the burden on heart. Arteriodilators mainly hydrolyzine, minoxidil, calcium channel blockers. They decrease afterload by decreasing by dilating arterioles. If heart is pumping, more blood will forward to the body parts. So thereby afterload will be decreased. Some drugs will have both actions. They decrease preload at the same time afterload also. What are those? ACE inhibitors. Okay. Angiotensin converting enzyme inhibitors like pril drugs, ARBs, losartan, telmisartan, like those drugs. Sodium nitroprusside, alpha blockers. Okay. Mostly we use ACE inhibitors and ARBs in heart failures. Okay. Next is vasopeptidase inhibitors. Vasopeptidase inhibitors, like they will have two mechanism actions. One is they inhibit angiotensin converting enzyme. At the same time, they inhibit neutral endopeptidase enzyme. Okay, this neutral endopeptidase means we will see previous slide ANP, BNP. This enzyme will act on ANP and BNP. Okay, so obviously it will by inhibiting this one, we will have more chance of retention of ANP and BNP. It will cause natriuresis at the same time vasodilation also. Okay, so this is recently developed drugs. Their main side effect will be angioedema. There will be one more drug also have chancing of developing angioedema, that is AC inhibitor also. Okay, those we will discuss in antihypertensive. When you are going with antihypertensive, we will discuss there. So next recent developed drug is ARNA, that is angiotensin receptor and neprilysin inhibitor. That means it is a combination drug. It is recently approved by FDA for CHF. It is having combination of valsartan plus sacubitril. Okay. That means they have angiotensin receptor blocking, at the same time neprilysin blocking activity. So these vasopeptides and ARNS are recently, so they have chance to ask these questions. Okay, what is the combination of in ARNA? What is the next one? NEP means neutral endopeptidase acting on which vasopeptides. Okay, here ANP, BNP it will act. Okay. Next drugs we use in CHF is beta blockers. Okay. Beta blockers means, if you in first slide I explained compensatory mechanism, right? There will obviously first kidneys will be activated by renin, right? So renin will be released by beta 1. So this beta blocker will inhibit renin, followed by renin angiotensin aldosterone system will get inhibited. So obviously when it is inhibited, obviously it will result what? Reversal of cardiac remodeling. So obviously cardiac remodeling will get inhibited. So what are the most common drugs we'll use here? Carvedilol, metoprolol, bisoprolol. Okay. So main precaution will be taken here is we should start these drugs will be low dose. Okay. Then we have to increase dose based on the patient recovery. The main contraindicator of using this drug is when patient is in decompensated heart failure. Okay. Compensation happen, no problem. When patient is not in compensation, decompensated heart failure, these drugs will decrease the cardiac heart rate. Okay, so it will be cause more serious problem. Bradycardia patient will have chance of death also. So when patient is on decompensated heart failure, we should avoid beta blockers. That's all. Thank you.